So now we are going to start our discussion panel 1. Nurturing leadership today extends beyond care delivery in defines safety, culture and clinical governance. Ladies and gentlemen, we now begin our first panel discussion of the day, a session that places nurturing leadership at the center of patient safety system excellence and future readiness, named Advancing Patient Safety Through Nursing Leadership, Reimagining, Excellent Education, and the Future Workforce. I invite Dr. Kausar Shah, Group CEO Sharda Care Health City moderator of the session to kindly moderate our first panel. I would like to call on panelists Colonel Binu Sharma, CEO INS India, Gina Jose, Nursing Superintendent Holy Family Hospital, Professor Dr. Ramendra Kalra, Principal cum Professor Holy Family College of Nursing, Dr. Saurabh Lal, Vice President and Hospital Director, Marengo Asia Hospital, Girja Sharma, Chief of Nursing, Fortis Hospital, Shalimar, Bagh. Please welcome everyone on stage. Can I have a round of applause for them?
Check. अरे check. Hey.
Thank you. Am I audible?
Check.
Audible? Hello. Am I audible now? Okay. Thank you so much, everyone. And I very warmly welcome to my fellow speakers for this very interesting session. But before we start, I have a very small thing to share with all of you, which is a small reality, speaking to you in a story form, but that's a reality which I'm going to speak about. And this will be leading into the discussion. So this is about an 83 years old man. The man had a stroke, and this was not in Delhi, somewhere outside Delhi. The family got really worried then, and the care in that specific city was not appropriately as it should have been, which was required for the patient. So the family reached out to a hospital which was close to their house in Delhi. They spoke to the people there. They said, no worries, please get him here. By the time the patient could reach there, the patient was in coma. Now the life was absolutely in danger. The entire family was in jeopardize. The patient reached there. The patient, as we all know, in a comatose state, is not just the medical treatment, it is the nursing care which makes the outcome out of it. The patient, after about a month's stay there, came out of it without losing the life. Yes, of course, the recovery was still not to the mark and the family would have wanted, but the patient's life was saved. A very emotional family thanked to the hospital which took care of this, and I know about this because the family who had called up to the hospital and the person who has called up from the family, it was me, and it was my father-in-law for who I had called up to the hospital, and the nursing which took care of my father-in-law, saved his life, was headed by Girja. So all the gratitude to you, Girja, and your entire team. With this, I don't want to talk only about Girja. Of course, there is tremendous thankfulness. But I want to bring about the attention to the nursing care which creates the outcome of a patient's, whatever the clinical condition the patient might be in. A doctor can write the treatment, a doctor can prescribe the treatment, a doctor can lay down the way the treatment has to be given, but a doctor is not the one who ensures what happens to the patient. It is the clinical care given by the nursing throughout 24/7 is what makes the final outcome of the patient in real sense. That's a reality which I'm very happy to see that we all are realizing. But the faster we realize to the best of its level, the better it is for the healthcare and of course for the patients. Having said that, so I think this deserves a loud applause for the nursing care in our country. Thank you. So starting with the pointers. So Girija, let me start with you only. So we all know that when it comes to the nursing care, there is a tremendous systemic failures which keep happening in our country, and especially in terms of the nursing care. Now, there are some systemic failures which are in control, which may not be in our control as well. But there have to be some obvious reasons why does it happen. So my question to you is, can we have some understanding from your side? What are the top systemic errors which are commonly happening in our country, which definitely require attention in future times in terms of nursing care? If you can just put up some light on that.
Good morning to everyone. What a wonderful opening, Dr. Kausar. You are absolutely right. Most patient safety incidents are not about the bad individuals. It is because of the broken systems. These are recurrent, cross-cutting systems which happens across the industry. First and foremost, I must say, is the poor communication between healthcare workers and the family. Inadequate handovers means handover between the shifts, handover OT to floor, floor to ICU, and even discharges. Hierarchical structures sometimes which discourages nurses and the junior doctors to speak up at the right time. Then verbal orders and unclear documentation also brings hazards to healthcare system. Language barriers, we don't communicate properly sometimes to the people, to the patient or to the family. That also is an issue, which is always resulting in wrong patient, wrong drug, delayed care, and misdeterioration conditions of the patient. Staffing shortage, especially in the nursing, which results high nurse-patient ratio, fatigue, burnouts, morale distress, excessive overtime, and rotating shift. This is one of the important cause of this. Even excellent resource can make errors in broken system. Workplace safety culture is also very important to reduce the errors. That is, in some of the organizations, we have blame game culture. We have punishment culture. We punish the people. We blame the people. We don't report near misses. So many near misses, which should be the learnings, but we don't report them. Leadership disconnect with the frontliners. Huge leadership disconnect with the frontliners. This is they say they have a different mindset. They say this is how we have done it always. How can you say it differently? That acceptance is not there. Inadequate training and competency system. In current scenario, there's a huge gap between the demand and supply. Demand of corporate hospital is there, we need a resource there, and the supply is here. To merge this gap, it needs at least 6 months to train a resource so that we can put it to the patient. Many organizations have inconsistent onboarding. They don't have simulation labs. They don't have skill refresher courses or centers. Staff is floated to the unfamiliar units. Suppose ward nurse is sent to the ICU, ward nurse sent to the ER, ward nurse is sent to the OT. Then there are highly reasons for the errors. Sometimes we introduce new technologies without being trained people on that. That is also a major reason for the errors. There is a fragmented care which is noticed in the healthcare industry and the poor continuity. There, for healthcare for a patient, it is multidisciplinary team which has to work for the patient, but everybody will work in silos. Doctor will be one side, nurses will be one side, they work in silos. There are multiple stakeholders which are there for the patient care, but there is no clear-cut ownership from them. There's a poor coordination which is across healthcare levels. Even discharge planning and discharge follow-ups are not proper, which always results in gap, duplication, adverse events. Medication safety system failure. Some of the hospital, if you talk about the smaller hospital, talk about the nursing homes, they will not be having any policy protocol for look-alike, sound-alike medications. There's lack of standardization on ground. There are manual prescriptions and prescription, which is prone to the errors. There are inadequate double checks for high-risk medication. These are the major causes for the errors. We have inadequate use of technology. Sometimes technology is poorly designed. Suppose electronic health records is poorly designed. It is not compatible with the hospital setup. Alert fatigue. People become insensitive about the alerts. Machine is giving the alarm and the person is not looking at it. Technology is not aligned sometimes with the workflow. This is also one of the reasons. We sometimes over-rely on the machines, but we don't rely on our own judgment. This is not one or the other hospital. This happens across the industry. And sometimes we don't learn from our data and from our incidents as well. Incident reports collected but not analyzed. Even if it is analyzed, the feedback is not being shared to the frontliners. It is there at the manager's desk. Root cause analysis is being done only for paperwork or to show the auditors that we are doing the root cause analysis. It is not shared with the frontliners. And after doing the root cause also, we don't change our systems, we don't change our protocols. Then leadership and governance gaps are also there. Safety is not prioritized at leadership level. We focus on targets, but we don't focus on outcomes. This is bitter truth of healthcare industry. Limited frontline engagements by the leaders. There are few leaders who are on the ground, they are committed, they work with the frontliners, but there are few leaders seen who are there in their offices, they don't interact with the people down. Safety is seen as quality department's issue. If we talk about the safety in the hospital, we think it is a department of quality who has to take care of the safety. But each and every individual is responsible for the safety. It is a bitter truth that patient safety improves only when leadership owns it. Otherwise, patient safety will never improve. Patient safety is not about who failed. It is about which system failed and how do we correct it. Thank you.
Thank you very much, Girja. I think it couldn't have been better than this, what you have said. You have covered so many aspects about this specific thing, about the systems being a failure. That's about the reasons or the causes of the factors. Now, Dr. Saurabh, if I have to ask you, what could be the ways to work upon these factors? I don't see that entire factors can be covered in a day or two, whatever, but at least some of the topmost factors which you believe are the main contributors towards the systemic failures. What could be your approach towards this, if I have to ask you?
Thanks, Dr. Kausar. So before I get on to the question, I think since this is a nursing excellence panel and you set the tone right, I would just want to share a small experience that I had in May last year. And I had gone to the NHS and I was walking across a couple of hospitals, and this happened in the Bristol hospital where I walked into the emergency and a very nosy Brit nursing head was showing the department to me. And when I was walking, I realized that her lanyard had an Indian flag. So I asked her whether she belonged to India or had an India connection because it didn't look like that. And she said that I wear this because the best nurses in my department are from India. So I think first of all, congratulations to the nursing leadership of the country that's sitting here. Many of us have worked together, but I felt so proud. And I think taking a cue from what you said, the West has learnt, devised, and implemented with our help. But we as Indian leadership of healthcare are still on our way. This also reminds me of, and I'm going to talk at a very strategic level. They're cheering for the nurses. So this reminds me of a concept, it's more of a management concept called the Cobra effect. I'm not sure if anybody's heard of the Cobra effect. Basically what happened when the country was under the British Raj was that the Delhi region was the capital and was confined to the walled city, which is the old Delhi as we know today. And the rest of the Delhi was thick jungles. And these jungles had a lot of cobras. So the British came up with an incentive scheme for Indians wherein they said that every Indian who brings a cobra head, who kills a cobra and brings a cobra head, will get an asharfi. Asharfi is a gold coin. So cutting a long story short, what the British realized over a period of time is that instead of reducing, the cobra heads actually increased by 10 times. And they probably forgot, or probably back then didn't know, that the sharpest minds come from India. Indians started rearing cobras in their backyards. And hence the asharfis became 10x. And I'm going to link this with our nursing strategies in our hospitals, because what we do is, we do not make strategies focused at solving a problem. Our problem statement is incorrect. One example is, we keep telling our nurses that it is good to raise incidents. It has to be done. Nobody will be reprimanded. But on the ground, at a nursing supervisor level, or maybe at the in charge of a nursing station level, even today, as most of us may not agree with, a nurse is dinged for raising an incident. And the fact is that when we sit with our nursing leadership, we always tell them that, nurses have to raise incidents. But what is that incentive? When a salesperson has an incentive, why does the nurse not have a tangible incentive to raise an incident? This is the most basic thing that comes to my mind. So in my opinion, these problem statements which Girja just shared have existed since time immemorial. But we as as hospital leaders, have to rethink our way of how to solve it. And when we talk of patient safety, I think the most obvious way to go forward is technology. So in my sense, so just to give you an example, few weeks ago, there was an event in the hospital and a company had come in. We had a very interesting engagement where we were asked to do a hand wash, and then there was a machine which told us how clean or dirty our hands are, the ultraviolet rays and all. Now my point is, why do we do this only on events? Why can this machine not be placed right outside every critical area? And instead of having an access control, so there is another analogy which says that more senior the person, lesser the infection will spread from that person. So these are those conventional thoughts of a hospital. Why can't we change this? And I always keep telling my team that, the easiest way for compliance is that remove the human being and put a machine. Every time a security guard stops a person, he will be rogered. But how many times do we go and roger a machine? So in my opinion, the problem statements are the same since decades. It is just that we need to rethink the way we look at these problems and relook inside ourselves on how strong our conviction to solve these problems are. So if we pick up each problem, I'm telling you, technology has answers to everything in today's time. So not going very granular, but in my sense, automation needs to come more into nursing. There are enough instances of hospitals. Our hospitals are testing a lot of things. There are a lot of startups coming up in the country which are bringing brilliant solutions. I think we as leaders need to start giving those startups, platforms for POCs, and we need to adopt this technology rather than making it an incidental, event-based POC.
Very well said, Saurabh, Dr. Saurabh. Your Cobra incidents actually reminded me of something. You know, when I started my career as a clinician, I was in one of the hospitals, and in emergency, is it functioning? Hello. Hello. Is this mic gasping or me gasping? Somebody's gasping.
We have enough people to revive you.
I know. I would love to be revived by these guys. Okay. Yeah. So guys, so what happened? I was in the emergency there, and a man came with a snake bite. And man came. He just took out a bag, small bag, the cloth bag. उसने उसको उल्टा किया. A snake came out. I said, "What is this?" He said, "This is the snake which bit me," and it was a cobra. So I said, "But where is the bite?" He said, "Sir, my bite is here." I said, "Okay." Then, "Sir, other bite is here." I said, "Okay." Another bite is here. Okay. Another bite is here. So the guy had about 15 snake bites on his body. I said, "What did you do? How did this happen?" And he was drunk also. So he said, "Sir, this cobra tried to bite me. He bit me here first." I said, "Aisi ki taisi teri." I wanted to kill him. Then he bit me here. I still wanted to kill him. He bit me here. He kept biting me. I kept trying to kill him till the time he killed. He was killed. He bit me so many times, and I'm here. Please treat me now. So that's typical about what Dr. Saurabh you shared, and I had a living experience of this. So having said that, Dr. Colonel Binu, we heard quite a few things. I think staff shortage, the nursing shortage to be specific, is a living reality which not just we in fact, which is a global emergency right now in fact. One of the reasons is again what Dr. Saurabh shared, that the outside our country, all the talented nursing staff is outside our country. So we are facing the brunt. But the point is, that's okay, we need to deal with this. So what can be the ways to deal with this in a way that the staff shortage can improvise at least in a few years down the line? Is there any thought about it which you can share, which we as a country can work upon?
Thank you, Dr. Kausar. Interesting discussion so far, remembering Cobra effect right from Dr. Saurabh Lal. Staff shortage is nothing new to anyone sitting in this room, whether nurses, nurse leaders, hospital administrators, doctors. This is the topic, the most painful topic, raised right from the morning meeting through the day at different level, different meetings. Everyone lives through it, but not everyone deals with it the way it should be dealt with. As of 2025, we have about 40 lakh nurses registered in the country. To be precise, 42 lakhs. Our population, we all know, has already crossed about 145 crores. Our country has about the average of 2 nurses or 1.8 nurses per 1,000 patients. Now, staff shortages we are here to live with. We heard example where best nurses are there overseas. I would give a small incident here. A few years back, I had gone and visited Singapore General Hospital. I had gone there for a cardiothoracic understanding. When one of my hospitals was starting cardiothoracic, they wanted an international flavor. Please go learn from Singapore General Hospital how to run cardiothoracic. I went there. I visited cath lab, CTVS, their critical cardiothoracic ICU, etc. I met the doctors and the nurses. I asked them, please share your best practices. That keeping aside, all the nurses who were managing the CTVS OT, the cath lab, and the CTVS ICU, including a couple of doctors, were all Indian. They said, Madam, हम तो इंडिया से ही सीख के आए हैं, हम आपको क्या सिखाएंगे? That's for Indian nurses and Indian doctors. Staff shortages are in every single hospital. I've been a nurse for about 48, 49 years. In the Armed Forces Hospital, where I worked for 25 years, we never heard of staff shortages. We learned how to navigate around it, not compromising with patient safety or clinical outcomes. When I switched from armed forces to the corporate world, for few years, I'm talking way back in the 2001, 2, 3, 4, 5, we still were not having staff shortage as a red flag. There were occasional times when we would have attrition. Attrition was controlled. Let's not go to the reason why. But lately, for last decade or so, every single private hospital, big or small, in a metro or a tier 2 or a tier 3, is having staff shortages. Do we know the solutions? Are there innovative solutions? What do we do? Starting point, I would say, in the private hospitals, although we say nurses are the backbone, they are the framework without which hospitals can't run or patients can't be managed, but we have not invested enough in our nurses in the country. We heard from Dr. Pasna in the morning, we have nurse practitioners, what can we do? In the US, they do this, they take all the decisions. Neither we have invested in their training, nor we have invested in the work culture, the dignity of work, what they should have, the compensation, the specialized training. So nurses find an easy way. Majority of our cream of nurses, well-trained people, if they do not have a major family issue, you will find them across the globe. This has been rampant for a long time and will continue to happen. We can't stop that outflow because nurses are paid better, they are treated better, they are empowered better, they have a say everywhere. So let's come to a few solutions which probably we can adopt. First of all, for us, nurses should not be a head count in the hospital. I'll go to technology. That's a very, very great point to handle shortages. But before that, let's do a proper skill mix and an assignment. Your master's nurse, BSc nurse, 10 years experience nurse, and your fresher or your A&M if they are there, they are all treated the same way. 5 patients for you, 6 patients for you, 10 patients for you. It has to be skill alignment. I would say if you want good safety, less attrition, and you want to control your staff shortages, align a nurse aide or a personal care assistant or a nursing assistant with each senior nurse in the hospital, whether they are in the intensive care or whether they are on a floor. They will do the advanced work based on their experience, their privileging and their competency, and the other people aligned to her will do the personal hygiene, the transportation, many other things. Let the ward clerk or ward secretary do the documentation. You want the nurse to do the documentation, you want the nurse to transport the patient, she is a porter, she is a clerk, yet she is a nurse of the advanced level, delivering highest care. This is bound to create staff shortages. This is point number 1. My point number 2 is usage of technology. Technology is advancing in our country, but is technology adding burden to the nurses and doctors, or is it solving their issue? Have you tested your technology platforms with the clinical user, which is doctor, nurses of operating room, intensive care, outpatient? Ask them what kind of formats and technology solutions they want. Is it simple to use? Of course, they have to be trained. Like you just said, they are not trained. It is not even discussed at the level of doctors and nurses. Hospital wants a technology solution, so be it. The same hospital may have 100 technology platforms working in silos but not talking to each other. Nurses have to navigate through a clinical EHR, then a inventory management solution of technology, then a diagnostic. They are going in and out of various platforms, and these are practical things I'm talking about. Will the nurse love technology? She will hate technology. Why? Because it's making her life more cumbersome, more time taking rather than solving. Another staff shortage issue is take away not just the non-nursing activities, which we all talk in every boardroom. Why there is a nursing shortage? Take away non-nursing burden, let them do the clinical work. And when there is a staff shortage, the first and foremost thing, at whatever cost, by whatever effort, retain your trained staff. Because the doctor, the patients, the medical admin, and the nursing leadership, everyone is standing on the head of those clinical nurses who are already overburdened, mentally stressed out, physically fatigued, no time for food, no time for washroom breaks, and on top, they do not have a voice to say, I've got too many patients, I'm sorry, I can't deliver the level of care the patient requires. Leave alone what the hospital wants. What the patient requires clinically, they can't possibly do it. Have nurses ready from the nursing schools and the colleges on time. Do paid internship. Nursing students come to all hospitals. In private sector, they are not given any clinical freedom. They are only observers. If a nursing student is standing in a patient room and observing, can they help you in staff shortages? No. Please train them and also privilege them. Coming to A&M point, which was taken in the morning by Dr. Upasana. A&Ms are trained. We have hundreds of colleges for A&M. How many corporate hospitals, private hospitals are employing A&Ms? Because we are not able to privilege them. NABH is not saying do not have A&M. It has to be for whatever they are trained, they are certified, they have to be privileged. So their privileges can be different. The other nurses, registered nurses privileging, BSc, MSc, GNMs, that can be different. Nurses during shortage time, leadership should have walked the talk, should be available at the site of the shortage. Let me quote the two doctors sitting here with both I have worked, Dr. Kausar and Dr. Saurabh. And I was in the same organization at different times. Dr. Kausar, a long relationship in two different organizations. When there is a shortage, I remember the times of dengue shortage. The entire hospital leaders, including finance, customer care, HR, everyone was tasked by Dr. Kausar to be on the floor to support nurses. Initially, they would have wondered, हम क्या करेंगे patients के लिए? But just the people from the manager's team standing on every nurse station, listening to nurses, trying to solve problems, interdisciplinary rounds, doctors giving a voice to the nurse. Doctor is the best person who can support a nurse, and he is the person who can break a nurse's morale. Can we have doctors, medical administration, everyone asking the nurse to speak first during the round? When there is a shortage, give them incentive, free meal, movie in the hospital theater, popcorn, cola. Pamper them when there is a shortage. They will not leave you. They will stand by you. These are ways of correcting. Correct their compensation. Give them respect. Give them individual status. Give them authority to speak up. Give them the power to raise incident report where a patient is suffering. A doctor has not reported to the escalation. He is not found anywhere. A senior nurse is not available. Medical admin is not picking up phone. We have seen all those things working magically when all of this is challenged and all of this is changed. Nursing shortages will be there. Fix the nurse-patient ratio in most high-risk zone during a shortage. If it is ICU, it is non-ICU, operating room, fix it. There should be a ceiling beyond which you have to stop admitting patients. It will have impact on your business, does not matter. Patient life, clinical outcomes, and safety is utmost important. These are some of the corrective measures I'm saying. I can go on for a day on that, but I'm sure we don't have that much of time.
I can make out because you were so filled with passion when you were talking about it.
Staff shortage,
So
my
filled.
God.
And
Each
that
of
is-
the nurse
that's
will
obvious.
agree with me.
Thank you so much, Colonel Binu. It's been mesmerizing listening to you. So I think you brought up two very, very important points. One is about the doctor's support to the nurses, and second is about the fatigue part. When it comes to the doctor support part, मुझे एक जोक ध्यान आ रहा है. Sorry, I cannot live without jokes in my life. So there was a psychologist who was called by the hospital management to talk to the nurses, understand how he can help the nurses in their morale and all. Now this was a revisit by the same psychologist. Earlier he had met the same nurses last time. So when he asked the nurses ke bhai kaisa kya chal raha hai, so nurses said ke all seems to be fine. Your one tip is very, very helpful to us, that whenever a patient screams or shouts or gets irritated with us, just echo a sentence in your mind कि ये तो बेचारा बीमार है, and then we don't feel bad about it. He said okay, and then the psychologist asked कि I have heard that the doctors also do the same thing with you. वो भी चिल्लाते हैं तुम लोगों पे, तब क्या करते हो, उनको कैसे हैंडल करते हो? तो nurses said we echo the same sentence, ये भी बेचारा बीमार है. So guys, I think it's very important. I am saying this as a doctor. It's very important to respect the nurses, to have their understanding how they're functioning. If we push a nurse to a corner, trying to safeguard the mistakes, the more mistakes will happen. So we need to give the liberty. We need to be standing with them, which is very, very important. Now, the second part you spoke about is the fatigue part or the burnout which happens. Now, I think Dr. Kalra, can you just help us about some ways or means or mechanisms where we can think about safeguarding the nurses from getting fatigue or the burnt out, because this exposes more patient-related issues. Thank you.
Thank you, Dr. Kausar. And I think my topic has been dealt largely by all the panelists. Fine, they have talked about what are the factors which lead to burnout. Fine, whether it's not that it's getting tired, it is emotional exhaustion caused due to the various factors as patient shouting or doctor shouting, or it is the shortage of staff or many other things that they are all confused about. There are nurses who are, as Kanabini was pointing about the quality of nursing education. Fine, when I talk about the quality of nursing education, I'd just like to quote over here that yesterday I was taking one session on faculty development program for Bihar Nursing Council, and there were different faculty from different colleges of nursing and school of nursing. And when we were talking about the quality of clinical supervision and planning for the master nutrition plan, clinical postings and supervised work, I was shocked to hear when somebody said that they have colleges of nursing, school of nursing run only by one principal without faculty. So if these nurses are going to come to the hospital, what is going to happen? Fine, there are colleges who have very good faculty. Go and see whether it is government or private, very good quality of nursing education being provided. But when I reached the place, you have spent 6 months training those people, but at the same time, what is that they are supposed to learn in 3 years or 4 years of training, 6 months may be too short. So they're all confused and it leads to burnout. There are many, many reasons which have been already pointed out, but what is required is how do we take care? They can be, I need to be taking care of myself. Self-care is something very important. Colonel Binu said that there are no bio breaks that they get. I know nurses who hardly drink even a sip of water during the shift. Entire shift goes without taking the water. If their physiological needs are not met, very important is I need to take care of myself. I must take a break, have a glass of water, come back and resume my work. There can be some, some few things being kept over there. You know that IC people will not be able to go out. Can you provide them with a cup of tea, coffee, with some snacks over there? We know people in the corporate culture, they work so much, but at the same time, the facilities which are being provided to them, there are some breaks, they know that whenever they feel they can go and have a cup of coffee, they can have some snack. are we thinking about those breaks for them also? Are we thinking about that the training which is required, we have got a new equipment, we need to train them. And if there have been some critical incidents, something which has really troubled them, do people go and talk? Very good examples given that yes, doctor coming and taking round and trying to understand and making voice for them, becoming a voice for them. But at the same time, there has to be a regular system. If I am troubled, should the ward in charge, the team leader, the nursing superintendent, CNO, so many people are there, some way that somebody is there to listen to them. If I'm alone looking after a unit, I do not know how to deal with the emergency, I'll be landing into burnout. If I am being told whom to contact, how to contact, how to escalate if your things are not being heard, those things are very important. If you have a proper orientation being given. Very important is that yes, if you have very systematic way of doing the things, somewhere we have to learn to say no also. Many times it may be demanded that we are running short of staff, please do double shift. I know a long time back when I was in RAK College of Nursing, when I talked to one of the students who had passed out and was working in, I will not take the name of the hospital, she said, I'm exhausted there within 6 months because every time we are being asked to do double shift. I was surprised, and that the HR from that person happened to come and ask about that we would like your nurses to go and come and work with us in our hospital. I said, I already had some interaction. My nurses, my students are not satisfied over there. Please go back and look into the service condition. Are you going for this? There are no facilities for residents and all provided. They have to travel long distance, and over that it is being demanded. Go and talk to them. And believe me, after a few years, I met that person again, and they said it was something which really hurt me very badly, and I have gone and taken care of those aspects. So these are some of the aspects which really need to be taken care of. We need to take care of ourselves, regular breaks. We have to ensure that every staff gets leave to have a break after the duty. Go and change. Very important is, let me not sit on the same chair and eat my food. There should be a different place for having food. That also makes difference. Plus, off the duty when you're meeting your colleagues, do not discuss about what is happening in the clinical. Have a break from them. You are away from those. There are many other things, but I think we're running short of time. Thank you.
Thank you. Gina, I know that you must have been thinking, "Mera number kab aayega?" So now it's you. So this one goes to you basically. So communication is a big thing in our industry. Till now, always it was being thought that the patient's outcome is primarily an outcome of the doctor and the nurse's communication with the patient. But of late, a third angle which has come up is there has to be appropriate communication with the patient's family as well, which also leads somewhere into the final outcome of even the clinical outcome. Do you agree with this? And what is the right way to do this? And I think now we need to be on the short answer type.
Thank you, sir. So I first quote the first sentence which I learned in the sociology chapter: man is a social animal. So we all are dependent on our family and to each other for our living. So when it comes in terms of hospital and family, it is very important that family should be involved, because family act as a support system for the patient. So along with patient, we are supposed and we are obliged to involve family members for the decision making as well as for telling about the patient treatment, because it not only helps or enables the patient, it also helps us for the adherence. Because as you know, long back, DOTS has been started in our country. Why DOTS has been started? Because tuberculosis failures were coming, right? And there were so much numbers were hiking up in tuberculosis. So we thought of, government thought of dots, where patient comes in and takes the medication by in front of the healthcare providers. But for every disease, we cannot have dots or a direct patient interaction. For that, we have to involve the family members, where we entrust them, we take them in confidence that taking care of their lifestyle, taking care of medication adherence, taking care of rehabilitation, they play a greater role, as well as they are the big support system for the patient. So I totally agree, specifically in the Indian context, we are so much emotionally connected to the family members, so they are the prime people to be involved with the patient. But here also comes as we have to take the confidence of the patient too in some of the other disease condition. But yes, for most of the disease condition, we can take their help.
Thank you so much.
So I have done justice of not taking much time.
Yeah, I completely agree. And do we have more time? Do we not have more time? We have more time till evening? You have dinner for us? No, no dinner. Okay. So, okay. But we'll still be on the short answer type. So, Kanal Binu, if I have to ask you about a very beautiful thing which is prevalent in our industry, which is very beautiful as a concept, the handover registers. But we know the realities about it. What can be done about this so that it becomes more effective, more impactful, and that, of course, creates the right outcome? Because that communication gap is what kills many things. Any comments on that?
Sure. So I would just say in brief, handover is a mandate, whether you look at NABH, whether you look at JCI, or you look at a clinical requirement of care. Handover is a mandate. Do we have a format? Is it very exhaustive? Does it work only as a tick list by nurses? Doctors don't even do the handovers most of the times, because you have to hunt into some drawers where they would have written down some notes. For safe patient care, for continuity of care, you need to have a S-bar kind of a structure, which is a format and which should be mandated, it should be audited. Unless you have a system where handover is very relevant, crisp, easy to document, does not take too much of time. Here, technology can play a very major role. I have seen couple of hospitals, including my previous one, where they developed some nursing app where when you are at a patient's side, definitely you need the outgoing nurse, the incoming nurse at the bedside, where you can have the handover in presence of the patient. That is a given. No compromise out there. No nursing station, मैं अभी जा रही हूँ या मैं अभी जा रहा हूँ and तू देख लेना. That doesn't work for patients. We are not in a back-end office. We are dealing with human lives who are critical, who are sick. So handover at the bedside, but the format can be supported by technology, and it really works beautifully where you've got all the critical scenarios listed down on the app and you just quickly see and you do not miss out. That must have a S-bar kind of a format. That is one. Secondly, handovers have to be at all critical levels. Communication for handover. Handover has to be audited. Not just setting up a form is not good enough. Let the authority, senior leadership, nursing, medical, and the hospital leader get the communication audit report on a dashboard for how many patients handover were done appropriately at the patient's bedside. And during handover, just one important point, there should be no interruption. Doctor round happening, nursing leadership round happening, supervisors coming, someone else coming. The moment you break the handover chain, you are bound to have more errors. And many studies have already proven that. So S-bar communication, mandated format, technology support to be monitored, to be audited without interruption should work well for communication and handover.
Thanks, Colonel Bino. And you brought about the point about the technical support in terms of handover. So I would request Dr. Kalra, can you just elaborate a bit? Because I believe if this can also be have an escalation matrix, where if the escalation has to go to the person next in line, where the handover hasn't happened appropriately, and I think technicalities or the technical support is the only way we can think about it. Any thoughts about it?
Yeah, I would like to add to, that we need to have a very formatted one, like ISBAR is there, IPAS is coming, and there are many other things which are there. The hospital has to have those things. I would like to mention here that one of our master students who's working under me, we have developed an app. It is being tested and soon it will be out, which is going to make handover process being documented. The handing over, which was taking around 15 to 20 minutes for one patient, it is taking just 2 minutes. Voice to text, the ISPAR format, it gets sorted out, and there's a checklist. And once it is, you are able to attach it to the hospital information system, HIS, the NS or anybody is sitting in the office can check what is the handover being done. No calls after that and no burnout with that. Just to say very much in brief. Thank you.
That's very nice. And in fact, I would have suggested the organizers to invite the people outside to listen to this. These are the opinions where they can create a product at, which is not in the industry right now. But anyway, so moving on to the next one. Girija, you spoke about, when you spoke in the first discussion about the incidence reports. No, incidence report culture is something which is not as a culture, but which is being pushed at almost all the organizations. But there are chances of this being used and misused as well. So I remember one incident, slightly funny. My finance manager, my finance head, he reached out to me. He said, see sir, what has happened with me? I said, what happened? So his cash flow report, which was a paper only, he must have been carrying in his hand, and he had gone to the cafeteria, hospital cafeteria only. By mistake, he just forgot it there. Now the operations manager, who was his contemporary, he picked it up. He raised an incidence report about this. Finance head has forgotten the cash report in cafeteria. Now he said, what do I do about this? I said, yeah, it's just a funny matter. But it brings me to a specific line that incidence reports can actually be used as something, as a tool against anybody or everybody, or maybe against each other. That's how it has been most of the time. If I am raised an incidence report against by, let's say, Dr. Saurabh, next time he will ensure he finds some reason to raise it against me as well. What can be the ways to actually make it more impactful and really make it more transparent as well in terms of real effectiveness coming out of the incidence reports for you, Girija?
Thanks, Dr. Kausar. You have put a finger on very beautiful point, which happens day in, day out, we are facing in the hospitals. This incident form should be a incident reporting, incident form should be a learning tool, not a confession box or a crime report. And why people are not fearing from filling the incident form, but they fear because of the blame game, the punishment people assign them. They feel that I may lose my reputation. They feel that I may be labeled as careless employee. And even if they fill the incident form, we do the RCA, and there will be no visible action on it. So, huge shift has to be there. From blame game to, we need to see that it should be a learning tool. Huge shift, until the shift happens, we will be never able to improve. And it has to be stop naming the individual when they make the error. It doesn't have to be the individual base. It has to be, where did system fail? Why did this error happen? Rather than blaming who made this mistake. Then incident report, sometimes people just think that disciplinary process and the incident is same. Incident report should be used at the learning time, whereas the disciplinary action should be only for the reckless behavior, willful violation, and substance abuse.
We have to be a little shorter.
Okay. Leadership must own the incidents openly in the public forums. Near miss should be discussed. We should improve on our own mistakes. And there should be what we learned sessions, and we should be done for the staff on ground. We should acknowledge the report, share the report, And we should see what was found there, how did we change the process, and what will change, and even if process cannot be changed, and why it cannot be changed. It should be clear to the staff. We should reward for good catches. Whenever any staff reports a good catch, that it should be awarded. Highlighting near misses in the reports in the meeting should be there, and it should be anonymous. There should not be any name written in the incident form, so the people are free. There should be smart and short reporting forms. And anonymous reporting should be there, and focus should be on what happened and not whose fault it is.
Can we move next, Girija?
Last but not the least,
Okay.
I just want to say, an
Okay.
organization that punishes
So
reporting
today's lunch is from me to you.
and trains the, but that means they are hiding the risk. An organization that learns from the reporting will save the patients.
Thank you.
Thank you.
So I have two more queries. You need to allow 5 minutes more. Okay? So 5 minutes more. Quick ones. Saurabh, we all have been knowing from the NABH also, they say for the quality and all, you need to have a budget. Do you think the communication or the patient incidences being reduced, it has a ROI in terms of finances or the revenues or, the cost being saved? Just a quick one.
So I have actually, in principle, done a POC where the moment you fix patient nursing issues, the ROI increases. It is inverse, it's directly related, maybe not directly, but related through channels. And I think there are two kinds of investments that need to be made. ROI in terms of financials and ROI which comes without spending money. And I'll deep dive into a 30-second example and won't take more than that. Many moons back when I was a surgeon and we used to go to the OT, there used to be this hefty matron of the OT in a government hospital. This is about Lady Hardinge Medical College in Delhi. And as house surgeons, as assistant professors, and Colonel Veenu probably remembers this example because it is part of every nursing address that I give even today. Before entering that OT, हमें अपने head of department का डर नहीं होता था, but that matron used to be in front of our eyes कि यार हमारा कहीं glove तो नहीं निकला हुआ, कहीं हमारा ये तो नहीं हुआ हुआ है, कहीं gown तो नहीं खुला हुआ. And that matron used to be so strict that as surgeons we used to fear her. But this was the same matron in the evening. उस time पे there used to be these thick syringes. वो क्या 50 ml वाली होती है? अब आती नहीं है. So there used to be these 50 ml syringes. The same matron used to pull out the piston, block it from the bottom, और वो glucose mix करके पिला देती थी. मास्क नीचे करके डॉक्टर साहब गिर गए तो हमें ही देखना पड़ेगा. The crux is, unless and until we as leaders, we as doctors accept that we need to empower our nurses, nothing is going to move forward. So that is the ROI of nursing without spending a penny of money, penny of cash. The other things, I think it's a longer discussion on technology, on AI, on ML. We are making AI models for doctors in the OPD, but nobody is thinking about making AI models on the nurse station. So I think we need another discussion for that. But my belief is that ROI will come. Actually, I've done a POC, so I know ROI does come. My cash percentage actually increased by about 10% by spending money on the nurse efficiency. So, cutting a long story short, I agree to the statement that ROI comes from nursing experience.
That's great. Thank you. So Gina, just the last one before she comes again on the stage and throws us apart out of the stage. The last one to you. The one is about the changing the culture. The organizations, they face the main challenge that the culture has to be appropriately laid down for ensuring the patient's safety. Any quick thoughts about it?
Sir, actually, as we always say, quality and safety is not the organizational goal. It has to be individual person's responsibility. So for achieving that, we need to have a strong leadership commitment. We need to involve patients for that too, because sometimes as a healthcare professionals, we are all busy in day-to-day lives. We come for rounds, we do our daily activities with 6 to 8 patients, we are busy. And hardly we sometimes forget to hand wash, for example. And if we involve our patients also, like if somebody comes to you, please encourage them for a hand washing. So it is a patient organization collaboration. So that ensure patient safety. Then again, as we said, non-punitive actions. Non-punitive, we all speak in big conferences, but at the ground level, we have to actually implement it. Actually, we have to pat up their shoulders and say, it's not a difference between a doctor or a nurse. It's that we together have, saved a patient. That should be the policy. So a non-punitive action as well as a proper positive reinforcement in which can be appreciation letter, which can be there in their file, as well as, many of the hospitals have a dashboard system also where you encourage such leaders, the safety champions, so that each and everybody gets encouraged or motivated to be a part of the total quality team. As I said, quality team is a member of 4 to 5 or 10 people, but the entire organizational member should be a part of patient and safety team, so that whoever comes to us in an organization should feel that we are in a safer hand and they should come back. Thank you.
Thank you so much. And to sum it up, let me again sum it up with a joke. A nurse died, natural death. She lanced into the hell. Of course, she was in hell. She didn't know she's dead. It took her 2 months to realize that she's no more working in the same hospital where she was working, and it is actually hell. So guys, let's not create that chaotic hospitals in our leadership skills. All of us need to contribute to that from top to bottom. Everybody has to be doing that. We need to create the right work cultures, right ways of working for the people, so that the outcomes for the patient safety also keeps coming up in the right manner. With this, thank you so very much. You allowed us extra time. We will not charge for the extra time for you. So thank you so very much. And it's a pleasure talking to all of you guys. Thank you so much.
Thank you so much, everyone, for your opinions and thoughts. So, for any questions, anyone? If you want to ask any question, you can. Any question, anyone? किसी को नहीं पूछना? Okay, thank you. For facilitation, I would like to call on stage Mr. Rudy Gall. There is a question. Okay.
Hello?
Yes, sir. I'll come.
Check.
You already have? Okay.
हेलो चेक.
हेलो 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 मैम, आपने बोला था, मैं हिंदी भाषी राज्य से हूँ, मुझे अंग्रेजी की भाषा का थोड़ा कम ज्ञान है. तो मैम आपने बोला था, वो लास्ट में मैम है, टेक्नोलॉजी जो है आप ज़्यादा सपोर्ट नहीं करना चाहते. टेक्नोलॉजी को आपने बोला था कि ज़्यादा सपोर्ट नहीं करना चाहते. ऐसा क्यों मैम? क्योंकि मैम डायग्नोसिस के लिए मैम टेक्नोलॉजी का सपोर्ट ज़्यादा ज़रूरी है.
हमने बोला कि टेक्नोलॉजी सपोर्ट से एफिशिएंसी बढ़ती है, नर्सिंग सेटिस्फैक्शन बढ़ती है, टाइम बचता है. लेकिन टेक्नोलॉजी ऐसी होनी चाहिए जो एक्चुअली टाइम सेव करे, सिंप्लीफाइड हो, ना कि नर्सेज और डॉक्टर्स और बाकी क्लिनिकल स्टाफ का टाइम और ज़्यादा डिले कर दे चीज़ों को. टेक्नोलॉजी होनी बहुत ज़रूरी है. टेक्नोलॉजी इज़ द फ्यूचर एक्चुअली फॉर हेल्थ केयर. होनी चाहिए.
थैंक यू.
Thank you so much, ma'am. Thank you so much, sir. So I would like to call on stage Mr. Afzal Kamal, sir, and Rudy Gol, sir, on stage. Can we have a huge round of applause for them? यू सो मच एवरीवन एंड कॉन्ग्रेचुलेशंस। तो ज़ोरदार तालियां हो जाएं हमारे इन ऑनर्स गेस्ट के लिए। थैंक यू सो मच एवरीवन। आप लोगों से एक चीज़ कहना चाहूँगी कि जब हमने दिन की शुरुआत की थी तो मुस्कुराते हुए की थी, तो अब दोपहर हो चुकी है तो फिर हम मुस्कुरा देते हैं, जोरदार तालियां अपने खुद के लिए बजा लेते हैं। Thank you everyone, thank you.